alaikum wa rahmatullah. Bismillah wa salatu wa salamu ala rasulillah wa ala alihi wa sahbihi ajma'in. Thank you all for joining us on this beautiful Saturday afternoon. My name is Yaser Ali. I am an estate planning attorney based in Phoenix, Arizona, and your host today. And most people, when we think about estate planning, we think about inheritance, we think about post-death transfers, and that's a lot of what we do in our practice, is help clients think about how do we preserve wealth and assets, and how do we transfer them efficiently and in a way that avoids the court system and minimizes taxes and is Sharia compliant. That's a lot of what we do with our clients. But today we're going to be talking about a component of estate planning that's very important, often neglected, and one that impacts almost everybody in some facet, either directly themselves or in the care and context of support for a loved one. So I'm very excited to have with me my dear friend, Dr. Ramy Salah. Just briefly, so you guys know, Dr. Ramy and I go back. Alhamdulillah, I met him when I was a first-year law student at UC Berkeley. And I believe, Ramy, you were the president of the MSA at the time. So we had a lot of fun at Berkeley. And alhamdulillah, Dr. Ramy is uniquely qualified to talk about end of life. And he is a hospice and palliative care physician in the Bay Area. I'm going to let him tell you what that means and what that entails. But mashallah, he went to Berkeley. He went on to go to med school and residency at UCLA. And now he's practicing back at home in the Bay Area as a hospice and palliative care physician. And Ramy, I think I have met thousands of Muslim doctors, and you are the only Muslim physician that I have met who is a hospice and palliative care physician. So why don't we start with, tell us a little bit about what that means and what that entails and what do you do? And then inshallah, we will get more into the webinar.
Sure. Bismillah, alhamdulillah, wa salatu wa salam ala rasulillah. I just want to say that this has been a long time coming between Yaser and I, and I'm glad that we were able to finally do it. And I'm glad that you took time out of your Saturday, to everybody on the call, to learn about this. You're right, there's not many Muslim palliative care physicians. We're out there. I've met a handful. But it's a unique field. It's as old as medicine is how I like to describe it, because at some point in history, the best we could do were things that were palliative, essentially relieve suffering, address pain and symptoms. And as technological and medical advancements came to be over the last century and a half, we lost sight of that and focused more on life-prolonging treatments, which are important. I'm glad we have them. But palliative care, especially here in the States, made a resurgence in the last, like the last quarter of the century, the 20th century, and now it's become an accredited field in medicine. Yaser asked me to share what differentiates me as a palliative physician compared to, say, an intensivist in the ICU or in the emergency room doc who, probably is around death quite a bit. And I think one of the things that I like to say as palliative care clinicians, physicians, what we do is try to see the forest through the trees, right? To focus on big picture. We specialize in communication, difficult conversations. I often tell my patients that I'm here to learn about you as a person and not just a patient, so that your treatments your wishes are honored with your treatments. So without further ado, if it's okay if I pull up my slides here, I do have some slides to share and go through with you.
Sure. Before we do that, Dr. Ramy, I want to talk just set the stage a little bit for this conversation that we're going to have today, because it's so important. As I mentioned, directly, there is a large, or a high percentage, and you can talk about, what percentage of people will face some component of incapacity and diminished capacity or inability to make their own decisions. And then thinking about who's going to make them for you and what voice will that person have. So I think that's one component. And then there's so many people who are tasked with, either intentionally or unintentionally, the decision making for a loved one, and that stressful process of how to make decisions when there was no guidance given. And so I think that's what a lot of people will be looking for. But one more thing that's just so important as Muslims is that this is a core component of our deen. You know, our whole faith is framed around thinking about death and constantly being in the remembrance of death and preparing for death. And the Prophet ﷺ mentions in a hadith, remember the destroyer of pleasures. And, we go about our daily life generally not thinking about death. And if we did, I mean, it's not intended to paralyze a person to not function, but it's healthy to think about death. And what's so fascinating is that, especially within a bunch of our cultures, ironically, more so than the general public, and feel free to tell me if this is anecdotally true in your experience, people think if I talk about death, I'm going to die. and how many ammus and uncles think that if I start talking about death, then I'm going to die. And so the better thing is to not talk about it, whereas it's such a core component, and leaving people behind with no idea what you would want, or leaving your decisions to healthcare workers that you've never met, I think is crazy. But I just want to just emphasize that frame for just a moment, that even when we think about other things besides this narrow discussion point, which is to say, there's a hadith of the Prophet ﷺ that he says that, a time will come where people will be feasting upon Muslims. And, the Sahaba asked that, will we be, وَمِنْ قِلَّةٍ نَحْنُ يَوْمَئِذٍ, like, will we be very few in number? Is that the reason why people will look at Muslims and just kind of, view them as free to take on the dinner table? And the Prophet ﷺ says, no, بَلْ أَنْتُمْ يَوْمَئِذٍ كَثِيرٌ, that you'll be so many, but your value is like the foam of the sea. And the hadith continues on about why. And the final point there is that it's because people will have wahan, which is hubbud dunya wa karahiyatul maut. It's this love for this world and just a, hatred for death. And like, if we think about the problems in the ummah and we think about how focused we are on our day-to-day life and not thinking about death, this frame, even though we're thinking about it from the practical, medical side, it helps orient and live our life in a purposeful manner. So I want to just lay that framework out for today, and then talk, and then I'll hand it over to you, just so everyone knows, inshallah, just a couple administrative housekeeping notes. You are free to ask questions in the chat. So if you have any questions as they come up, ask in the chat. We'll do our best to address them. I won't promise that we'll get to everything. There's a lot of material, and we want to be respectful of your time. So we're going to take about an hour, inshallah, to try to cover the topics for today's program. If we don't get through things, inshallah, we can have another conversation, or you can reach out to us if it's something more, that you want to address. But we're going to cover a little bit about palliative care and hospice, as Dr. Ramy alluded to his work and what that entails. Then we're going to look at, what does death look like? And, how do people die and where do they die? And some statistics around that. And then I think most interesting, Dr. Ramy is going to present 4 case studies. So we're going to move from theory to practice, where we have these abstract concepts of death and dying and, directives and DNRs and all of that, and then move them into actual real life examples, so that will help you to think about how to make these decisions. And then finally, at the end, we'll come back and talk about making sure that we have a plan, right? So that it's not just left in the abstract, but that we actually focus on creating our own advanced directives and living wills, and how to do that, inshallah. So without further ado, I will go ahead and pass it over to Dr. Ramy.
All right, Bismillah. I want to start off, like with any talk, with a couple disclaimers as well. And if I could really give all the disclaimers I wanted to give, I think it'd take the better part of this talk. But the main important ones are, number one, I'm here in my capacity as a doctor, first and foremost, although of course we'll pull on Islamic teachings and traditions, and I find inspiration in them, as well as studies and academics and ethics. I'm mostly here as a doctor. That being said, none of this is medical advice, right? Personal medical advice. And lastly, the second thing I wanted to share was what Yaser talked about, is that we're talking a little bit about a lot of things. When we met to prepare for today, Yaser kept going about, talk about this, make sure you talk about this, don't forget that. And when I looked at my notes at the end of our pre-meet, it was a whole page. I said, Yaser, you've given me like 5-6 hours worth of material to cover. So it is scratching the surface on a lot of things. This talk is academic as well as religious, as well as medical, as well as ethical, and so it touches on all those components around this important topic of end of life care.
Ramy,
So
before
yeah,
you go on, just I have to echo that disclaimer that this is also not legal advice. You know that, I am a lawyer, not your lawyer in this process until we engage. And so our goal is really to help you understand these concepts. And then, inshallah, if you would like further assistance in preparing the documents, we can help you with that separately. But our goal today is a general overview, as Dr. Ramy alluded to.
so by the end of this talk, I'm just listing a couple objectives that you're going to be able to do. First, we're going to talk briefly about the field of palliative care and how that's differentiated with hospice. It's often conflated by the general public, but even people in the medical field don't get the differences. Um, we'll talk about picking a good healthcare agent and the 4 qualities that I list that make a good one. We'll talk about themes around redemptive suffering, harm, some autonomy around from an Islamic viewpoint. This is more cerebral part of the talk. In terms of practical stuff, we'll talk about the 2 forms that come up for many people at the end of life, and not necessarily end of life, but just talking about it. Advanced directive and the physician order for life-sustaining treatment forms. Those are often confused as well. And throughout my talk, and perhaps the most important thing, is that we will draw on inspiration from the best example, sallallahu alaihi wasallam, and how he lived his last days on earth, how he dealt with serious illness, sallallahu alaihi wasallam. And I think whenever we lose our focus in these decisions, we can go back to the sunnah of Rasulullah alaihi salatu wasallam to get that inspiration and to kind of refocus us. So first, what is palliative care? Palliative care is is a very misunderstood term. People often think about death, dying, end of life with palliative. It's a very hard word to say just physically with the tongue. I'm not a huge fan of it. It was coined in 75 by the surgeon in Canada, and it comes from the word cloak, right? And just like that, we're here to relieve suffering, wrap around people, keep them warm when it gets cold, essentially. This is the Center to Advance Palliative Care's definition of it. And when we're talking about palliative care and hospice, the first sentence talks about the similarities, and the second sentence talks about the differences. So the first sentence is for patients or people living with serious illness. So in my practice, I'm seeing patients with advanced cancer, heart failure, lung disease, renal disease, dementia, etc. And our main goal is to improve quality of life, not just for the patient, but for their circle as well. And we take a holistic approach. We say physical, psychosocial, emotional, spiritual care, all in palliative care. And hospice does that too, as a team. The difference, though, is that palliative is dependent on the needs of a patient and not the prognosis. Prognosis is a term that usually is used to share life expectancy, how long a person has left to live. And the hospice benefit in the United States, at least for most populations, you have to have at least a 6-month or less prognosis to be enrolled with hospice care. So palliative can be involved at any age and any point, and it can be delivered with curative treatment. What does that mean? In hospice, patients will forego certain medical interventions like chemotherapy for a patient with cancer, or hospitalizations. They usually don't want to see the inside of a hospital again. With palliative, those can be concurrent. And this is highlighted in this graph, essentially. Palliative care is best delivered when we get involved upstream. That's when you have the best outcomes with improved quality of life, better conversations, better end of life outcomes. So it's good to get us involved early on. There's just a lot of barriers sometimes, and usually they're cultural or societal barriers that prevent us from getting involved when we'd want to. And the focus of palliative versus disease-directed therapies change over the course of an illness. And so finally, towards the end, usually it's more about relieving comfort until patients enroll with hospice if they're at the end of life, or sometimes they're cured of their disease and they go on. I always like mentioning this study. I'll mention a couple studies today, medical studies. This is one that palliative care clinicians really love. And I think it highlights many points, not just medical issues, but also kind of contextualizes end of life care and the murkiness around it. This was done in 2010 when stage 4 non-small cell lung cancer, people with that diagnosis usually lived on the order of months. They didn't really make it past a year. Now, with immunotherapy, things have changed, alhamdulillah. But what they did here in 2010 was they divided 150 odd patients between standard of care and then also to early palliative care, seeing palliative care within 2 weeks of diagnosis. Um, and what that team was pretty bare bones. I believe it was just a nurse practitioner and a social worker in a clinic, and they didn't see the patient very often. In my practice, we have a doctor, nurse practitioners, social workers, chaplains, nurse coordinators, and we do home visits. So ours is more robust and probably one of the more robust palliative care clinics that you'll see. Um, and what did they see in terms of outcomes? Well, number one, their quality of life scores improved with palliative care. That's not surprising. You have a team focusing on this stuff, you're going to have better quality of life scores. Their mood scores improved as well, especially with depression, went down with early palliative care. Again, not surprising. But the surprising part of this study is that patients with early palliative care, though they had less chemotherapy in the last 2 weeks of life, less ICU stays, fewer ICU stays in the last weeks of life, and more likely to sign on to hospice care sooner, they lived longer. The difference here was an average of 2.7 months. And although that might not sound like a lot to most people, like 2.7 months, for this population, I describe it as a lifetime. And if you'd see a chemotherapy that showed 2.7 month survival in this population, you'd see it in the commercials in your Sunday football games. I mean, that's how big a deal that was. Now, I don't say this to say get palliative care, it's going to prolong your life, because I'll be honest, the main goal of palliative care is not to prolong people's lives. I'd love to see that, but the main goal is to improve quality of life, to address symptoms, to have tough conversations, and to make sure the care people get matches the care people want. And of course, that's derived with things like values, religion, priorities, goals, etc. So really quickly, just to summarize this portion, palliative care focuses on symptom relief, quality of life, patients with serious illness at any age and any stage. Hospice, truly end-of-life care, and focus on comfort where certain interventions are foregone. So now I'd like to pivot and talk about the landscape of dying. I usually start off my talks with this, and honestly, it's good to put it into context that every facet of life has drastically changed over the last century, right? Human beings haven't seen as much change as they have in all of human history as they have in the last 50 to 100 years. I mean, and Allah only knows how it's going to look 100 years from now. And dying is no exception. And Yasser talked about this when we were framing this conversation. Our attitudes, unfortunately, though our tradition is rich, Rasulullah ﷺ was generous in talking about how we should have this relationship with death and dying, right? When he talked about the wisest people, ﷺ, he said, أَكْثَرُهُمْ لِلْمَوْتِ ذِكْرًا, those who are abundant in the remembrance of death and the best in preparing for what's after it. But unfortunately, as a Muslim community, we weren't immune from the unfortunate change in society and culture in our attitudes towards death. It's become medicalized. Dying is not a medical process, but it's a human one. It should be, inshallah, a spiritual one, but it's become a medical one, right? And it's also been a forbidden death, as Philip Aries puts it, something concealed, something far away. You think 150 years ago, death was, at least for us in America, we're privileged. We don't see death very often. But you can get, even in America 150 years ago, children would see death all the time. Women would go into childbirth not knowing if they were going to come out or not. I mean, this was a part of daily life. And unfortunately, I think the medicalization of death, the concealment of death from society has led it to be a taboo topic, even though Islam teaches us otherwise. And so I'm hoping, through this talk and through these slides, you become a little more comfortable with the topic, a little more comfortable in talking about it with your loved ones, especially. The first question about what does dying look like is how we die. And this is a graph looking at statistics from 2016 of all the causes of death, right? Between heart disease and lung disease and sepsis and so forth. I think the more important graph, though, and this is for people 65 years or older, the more important graph is this. 70% of us, if we make it to 65, may Allah subhanahu wa ta'ala give us long lives, will die from a chronic illness. What is a chronic illness? A chronic illness is an illness that takes many months, sometimes many years, to that people can live with until they eventually die. And I think, lifespan, despite the little blip with COVID, lifespan has increased, right, with time. Um, but the disease-free years have not, meaning people are living longer than ever before, but it's because we're living longer with illness than ever before. So we're sicker, right, for longer. And I think chronic illness does one of two things. Ideally, it should put things into context, especially for us as Muslims. We're dealing with illness. Now our mortality is front and center, right? We are getting ready. We're calling Yasser and getting our estate planning in order. We're, figuring out our affairs. We're having these conversations. We're reconciling with family members, and we're getting ready to meet Allah subhanahu wa ta'ala. May Allah make it the best days of the day we meet him. Ameen. So that's what it should do. However, what it truly does, I think, in practice is it builds up this culture of denial as if we're going to live forever. These are four trajectories with different disease processes. I won't get too into it, but I want you to focus on the top right there, the entry, re-entry loop. And this helps kind of deliver the point that I'm trying to make. That for a patient with heart failure, for example, heart failure is a condition where the heart is not pumping as well as it used to, and fluid builds up in the body. There's a lot of strain on the heart, and it's a serious illness, right? But what happens is, although the trajectory is one of decline over time, there are these moments where it gets really bad really quickly. Patients go to the hospital. Doctors are great at optimizing medications and dosages, tuning a person up, and then discharging them back home, back to the baseline that they were at. And this can happen many times. The highest reason for admission to the hospital after infection is heart failure. And it happens again and again and again until finally when it happens and medicines can no longer bring a person back to baseline. And what I see in my practice often is, no, this happened again like 5 times before. All you got to do is get the dosage right. This doctor doesn't know what they're talking about. That last doctor was able to optimize medications. Oh yeah, we had another doctor tell us he was going to die, and then now look at him 3 months later, and he was able to get home. And so it gives this false sense of, immortality, really, thinking medicine is limitless in its ability to cure a person. We know the hadith of Rasulullah sallallahu alaihi wasallam, لِكُلِّ دَاءٍ دَوَاءٍ فَتَدَاوُوا, like for every illness is a treatment, so seek treatment. But we forget the second part of the hadith where Rasulullah sallallahu alaihi wasallam says, إِلَّا الْهَرَمْ, except old age. And I believe in another narration he mentions death. And so we have to be aware of our mortality. I think this is a good time to bring up one sunnah of dying. Rasulullah sallallahu alaihi wasallam acknowledged that his time wasn't long in the world to those around him. When he sent Mu'adh bin Jabal anhu out, he said, when you'd come back to Medina, you'd be visiting my grave. So he shared that information. In one of his last sermons, he mentioned the story of a slave of Allah who was given the choice between Zahrat al-Dunya, the luxuries of this world, or that which is with Allah. فَاخْتَارَ مَا عِنْدَ, and he chose that which is with him, with Allah subhanahu wa ta'ala. And we know his last words, sallallahu alayhi wa sallam, was Rafiq al-A'la, choosing the higher companionship with Allah. And so acknowledging your dying, sharing that to the community that you find important, usually your inner circle, your family, right, is a sunnah of dying from Rasulullah sallallahu alaihi wasallam, and one that is lost. I think usually when I see it with families, it's everyone knows it, but no one voices it. No one is able to say, this is happening, this is what I want, this is what's important, etc., etc.
Dr. Ramy, before
Yeah.
you continue, I mean, this is beautiful. And subhanAllah, like as you mentioned, our tradition is so rich here. I ironically think, and I'm sure that you deal with this on a more frequent basis than I do, that perhaps other faith groups are actually better prepared. I mean, you find a lot, and this is the point I made earlier, like we as Muslims in America, like there's no shortage of doctors. Certainly, if there's an overrepresented group, it's physicians. But like by and large, at the communal level, like we're not prepared at all for death. So do you find the other faith groups have like more structure around this process? Obviously, they're not thinking about akhirah, but they are thinking about end of life a lot more, it seems.
I think more than faith groups, and we can delve into the demographics of the Muslim community in America. I think it has more to do with, minority, being a minority, and also socioeconomic status. There's a huge level of mistrust. Rightfully so, I'm going to say, right? It's founded in true institutional racism that minorities face when they go to the emergency department. And so there's a wall, a curtain of mistrust that we're starting from when the doctor talks to us or talks to mom or tells us this very devastating news that's founded in real evidence of racism and implicit bias. And so there is a piece of privilege, that other faith groups maybe are more likely to be prepared. I think the same is true for estate planning, right? People of privilege are more likely to reach out to an estate attorney. People of privilege are actually more likely to get palliative care. It's terrible. I wish it wasn't the case because I think some of our most underserved communities need it the most. And so I think that's a bigger topic. And yes, I think as a community, I feel good, confident in saying, not good, confident in saying we're wholly unprepared for this stuff. Where we die is the second question. And this was pulled in 2016 as well for patients older than 65. The remainder percentage, emergency room, clinics, and other places are not included here. But the three most likely places that you and I and all of us will die are either in the hospital, number one there, a skilled nursing facility or a long-term care facility, number two, and then home. And although with time, thankfully, I think I could say thankfully, more and more people are choosing and are able to die at home than in the hospital. I think that's a big discussion there. But before I get into it, that is also rooted in the Sunnah, right? Rasulullah sallallahu alaihi wasallam, when he first had the fever, he was at our mother Maymuna radiallahu anha's chamber. And when Ali al-Fadl radiallahu anhuma brought him to the family and he asked the question, sallallahu alaihi, where shall I stay? Everyone knew that he was implying to stay with Aisha radiallahu anha. And so he moved from the chamber of Maymuna to Aisha, the chamber of Aisha. And that was that choice of where to die is a practice in the Sunnah. On top of that, although this is a loaded comment here, dying at home can be looked at as a sunnah. I remember I was in a talk where the sheikh mentioned that if there were any more honorable way to die than at home and in the arms of your loved one, Rasulullah sallallahu alaihi wasallam would have died that way. Now, I think there are a lot of angles that we have to discuss that. It's not always possible to die at home. And that's because what I said earlier, we're living with chronic illness longer. And so that's affecting our caregivers. Most of us are not just having a 10 to 14 day stint with high fevers and sepsis and infection. We're dealing with cancer for many years or dementia for many years where they need constant supervision. And so there have been studies showing that caregiver burnout and caregiver health, right, and how often they utilize hospitals and clinics actually go up when their loved one dies at home. And so practically speaking, many people have to either be or hire caregivers, and that's not cheap, especially here in the Bay Area, to actually achieve death at home. It's not always easy. So I wanted to offer that, that caveat there. All right.
Just
So
one
now we'll go into yeah, go
if
for
you
it.
will. I think maybe one point that's a really beautiful point you make, which is to say the likelihood of that home death occurring in the absence of articulating that wish is probably going to be less than if that plan were made in the directive, or at least wishes articulated to family. Like, I mean, how is someone even supposed to know that that's a wish that someone has? I think if you polled people, you'd find that most people would want that, but how many people have articulated that wish? I think very, very few.
or put it down on paper.
Put it down on paper, much less, but even just
Yeah.
like a verbal conversation to that effect.
There was a
But
good
certainly on paper, without question.
there was a good article from years back from one of my mentors called "Rehab to Death," and we see this cycle at the end of life for older patients. We may have seen it in our own families, where a patient goes from the hospital to nursing facility, home, then hospital, nursing facility, hospital, hospital facility, until finally they die, and it's mess. I mean, it's stressful, these transitions, and no one's having the conversation to say, all right, this is what's happening, what's important. And so that's a good segue to the first case here. And I think this applies probably to the majority of participants here. I don't know who's on the call. I'm assuming most are Muslim. Probably most are younger and maybe not dealing with serious illness. And if you are, may Allah make it easy. But this is a case of a 45-year-old Muslim man who's otherwise healthy, and he does something that maybe probably most 45 Muslim men don't do. He scheduled a regular checkup with his primary care doctor, and everything, alhamdulillah, checks out. Right? Labs come back pristine, everything is great. So the doctor says, I think it's time to fill out an advance directive. She's being a good doctor. And the Muslim man says, I'm not filling that thing out. Only Allah knows when we die. Ah, so this is the thing that we talked about a little bit earlier. Is talking about the future and dying going to actually make it happen, right? So what is advanced care planning? Many people put a D on advanced. There's nothing advanced about this. This is actually better read backwards. It's planning for your care in advance. So you're thinking about the future. And the two real components of advanced care planning that I want to say is number one, writing things, putting it in a document, an advanced directive that we'll talk about shortly. But more importantly is the conversations, right? The conversations that you're having with your spouses, with your children, if you're older, with whoever you designate as decision maker or healthcare agents. So one of the two things that an advanced directive, the document, achieves is number one, it designates that healthcare agent that we talked about. And we'll go about that in the next slide. And number two, it writes down your preferences. That's the directive part. If time were short, if you were dealing with some irreversible condition and doctors thought that death is imminent, how would you want your care to look like? What's important? And usually there are no shortage. Unfortunately, maybe it makes it confusing of the types of or versions of advanced directives. Each state and has its own kind of requirements. So if you're in California, you'd have to find a California one, Arizona, et cetera, et cetera. And then within each state, there's probably dozens and dozens and dozens of versions of advanced directives. And one thing that I think would be that I've seen in other faith groups is an advanced directive that's legally valid, right, and applicable, that really uses language that makes sense for us as Muslims, right? And we'll talk about some themes that come up at the end of life shortly that you can kind of have in an advanced directive. So before I turn it to,
let me
yeah,
jump in here for a second. I think that this point is so important that there are so many directives, and what's even more perhaps confusing for folks is that the studies show over 60% of people in America don't have a directive. And then the question is, okay, well, there's so many online resources that allow you to create a directive, but that doesn't necessarily facilitate, because the directives have such complex language within them in terms of what interventions you would want or not want. And perhaps the irony is that the logical place for this to happen is inside of a doctor's office, where this doctor just made the advice to the patient to create a directive, but that doesn't really happen. And where this usually happens is in the lawyer's office, right? So in the context of creating an estate plan, you'll find that any comprehensive estate plan includes a directive, but the lawyer often is not well versed in the medicine either. I mean, obviously, it has no medical training. So it's just it's a really interesting space, because most of these directives happen in, I think, the lawyer's office. Most people don't go to a lawyer, and so they never get done. And then the self-help forms that are available, certainly they're not tailored to us. And inshallah, one of the goals that I really have, and I was so excited to work with Dr. Ramy on this webinar, is that inshallah, our goal is to build an Islamic directive that can be valid in all 50 states, because all 50 states also have unique signing requirements. And so what happens so many times in estate planning in general is when people come to my office or contact me with self-help, they didn't execute the documents correctly. So if there's a notary requirement, perhaps they didn't get it notarized, or if there's 2 witnesses, they didn't get the witnesses, or like they got the witnesses, but they didn't do the witnesses and the notary at the same time when they were supposed to. And so you end up with an exercise that's incomplete and thus not legally valid. So there's so many barriers, and inshallah, our goal is hopefully make dua, and we'll hopefully follow up with this, but to try to develop a directive, as you said, that's culturally competent, addresses from the Islamic ethics perspective, what type of care we would want and end of life that we can use in all 50 states that will produce and be state specific. So that's a goal, inshallah, that we have. Hopefully we'll work on.
Yeah. So that's an advanced directive. You're absolutely right. Yes, most people do not have advanced directives. And studies show that if you are admitted to the hospital for patients, this was for patients over 65, there is a more than likely chance that someone else is going to have to make a medical decision for you. And that is heightened within the last 3 days of life. So literally life and death decisions are usually, are voiced, I would say voiced by your healthcare agent. Inshallah, I mean, you had already made decisions or have given a guide around these decisions to that healthcare agent before they're called to task. So this is a good time to visit what a healthcare agent is. They're also called decision makers. They're also called durable powers of attorney for healthcare, healthcare proxy. There's a lot of words for it. But essentially, it's who would you want to make medical decisions on your behalf if and when you are unable to make them on your own? Some people actually, even though they're able to make those decisions on their own, already appoint somebody else. And I think Western clinicians or Western trained clinicians have a hard time with that when mom says, just ask my son, and I don't want to know about my diagnosis. And they're saying, no, you have to know. That's an autonomous decision, and we have to honor that. As long as she's asked the question, do you want to know, or do you want your son to handle this or hear about this? There are 4 qualities that I like to use. The first is that they know they are a healthcare agent, or they're listed as a healthcare agent, and you would be surprised how many people list their brother, their cousin, their friend, and that person has no clue. I'm actually dealing with a case right now with a patient who doesn't have capacity, listed 5 people on an advanced directive some years ago, and none of the 5 want to serve in that role. And so it's a mess now. And so you have to say, wife, husband, child, friend, you're my durable power of attorney. Are you okay with that? And guess what? If they say no, alhamdulillah, you found that out before they were actually called, to pull the plug or what have you. So that's number 1. Number 2 is that they're available, reachable, and reliable, right? They don't necessarily have to be living in the same area, although sometimes that's the ideal scenario. But don't give me the cousin or the friend who's traveling or who never picks up the phone. They got to be reliable and reachable. Number 3 is that they know your wishes. So I said already, these conversations. Hey, did you see how Auntie died? I would never want that for myself. Did you see how Baba, went through his treatments? That's something I would want for myself if I was ever tried that way. These are the conversations to have with that loved one or healthcare agent. And then last but not least is they have what I call the emotional fortitude or wherewithal to make decisions on your behalf and not what they think, they want or they would want for themselves or they would want for you. I give the example of me and my brother, right? My father chose me as a healthcare agent. And my brother, even though he's older, we know that he would have a hard time with illness. He gets anxious around illness. So he would serve in a lot of better roles than I would. But for healthcare decisions, better to leave to me, right? Or better to have me listed there. So that's important to know as well. So just to recap, that they know they're reachable, reliable, and available. They know your wishes, that they know their healthcare agent, they're reachable, reliable. They know your wishes, and then they have the emotional fortitude to act on them. Yes, sir? You
Yeah.
had something to say?
So we see this all the time. And in fact, I was, as you were talking, I was kind of smiling because we've had clients name you as the agent. And I don't know if they asked you or not for permission.
Me? Oh gosh.
And but I get this all the time. Like people like to appoint their imam, for example. And I always say no. And I'm like, the poor guy, imagine he has 100 people who he's supposed to be the healthcare agent for, not to mention that the imam generally has no training in any of these, in these situations. And so I think it's really, really, really important to pick the right people. So many times, you want, when we go back to your notion of like a spiritual death, you want death to be a time of Quran, a time of dua. People are surrounding you, like but instead, I mean, there's so many times and situations where people are just fighting,
Mhm.
and what could be worse at that moment. And so the careful thought about who you're designating and accessibility, you could then tell that person, hey, listen, before you make a decision, I want you to make shura with such and such other
Right.
people, but don't put the burden of reaching them if they're not available, right? Whether that's
Yeah.
somebody overseas or someone who's the local sort of leader, the Muslim doctor, right, or the imam or whatever. But I think that's important. And then perhaps one more thing, this might be a little offensive in cases, but sometimes it's just important, which is like, if there's one person you definitely don't want to be making decisions, I think you should articulate that as well.
Mhm.
I mean, I know it sounds offensive, but like if this person is like just not like, if they, that they're going to come up with a different view than everybody else, like you may want to articulate that expressly. And so it's not intended to offend, but it's intended to make sure that you receive the care and wishes that you would want. So
That's um, I'm gonna flow through this really quickly. I always talk of the directive part, right? So what treatment decisions are important for this person, right? Or for you in your advanced directive. And I usually bring the schematic of a tree, a decision tree, a different type of decision tree. If you think of the roots of the tree, that's your health status or your prognosis. This is the most important part to establish. My goals as a young, I consider myself still young, man, is much different than what my goals would be or my priorities would be when I'm 90, inshallah, right? And so having that information is first. Now, studies show that patients expect their doctors to bring up prognosis with them. Studies also show that doctors aren't the best at bringing this subject up. In fact, many doctors, when they do, overestimate what the prognosis is. That being said, I encourage family members or patients to ask the tough questions. Hey, doc, you've known me, you know what I'm dealing with. What can I expect for the future? Is there anything you can tell me about my life expectancy or something like that? And sometimes they'll shy away from giving any, answer, which is fine. I encourage people to focus not just on time, focus on function. Like, hey, she's dealing with this. What is life going to look like in the future? That's also important. Now, at the branches of the tree are medical decisions. And I listed a lot of the end of life medical decisions that come up. And very often, it goes from roots to tree in the context of, modern medicine. A patient's in the hospital, maybe they're incapacitated, they're delivered this really devastating news about their diagnosis or the progression of their cancer or how bad the infection is. And then immediately the family is asked to pick a branch, like they're picking an appetizer from a menu at a restaurant. Like, what would you want? Or what would he want? And trees don't grow that way, and conversations shouldn't happen that way. Now, sometimes doctors and hospitals are pressed for time because things are really urgent, emergent, and these conversations haven't been had in the past. The best way to avoid that, though, is to have these conversations before that point and focus on what the trunk of the tree is, your goals, your values, your priorities. So, in my consults with my patients, if they're an hour long and I'm talking about medical decisions, 75%, maybe even more, is talking about the type of person they are, what's important to them, what makes life worth living for them, what hopes and worries they have. At the end, I use my clinical judgment and having known them, gotten to know them, to tell or recommend or guide a patient and their family as to what branch makes most sense for their values and their goals. And as Muslims, our trunk is huge. I mean, there is a wealth, so much that we can derive from in our faith and our tradition about how end of life care should look like and what treatments make sense. Now, this is a good point to make about seeking treatment and seeking medical treatment. It makes its rounds around, Islamic legal conversations and ethical conversations. in medicine, right? Is there an obligation to seek medical treatment? And there's a lot of difference of opinions and a lot of angles to address that question, right? Are we talking about a lot of times it's couched in the efficacy of the treatment, right? Is it fairly certain that this treatment is going to help? Is it غلبة الظن? Is it presumptive that it would? Is it mawhum? Is it just like throwing darts in the dark and seeing if it lands on a bullseye? And that drives the conversation as to whether or not seeking medical treatment can either be, wajib, to actually disliked, makruh, if it actually, the harms outweigh the benefits. And that's the second piece, harm. Medical treatments in the past, they weren't as harmful as they are today. If I tell you about taking Tylenol as a treatment for your pain or your fever, as long as you're under the 3,000 milligrams in a 24-hour period, it's a fairly safe drug. You're going to be fine. And so there's no harm, usually, no harm associated with taking Tylenol. If I'm talking about chemotherapy or CPR, and we got to also talk about harm. And Rasulullah sallallahu alaihi wasallam said, "La darar wa la dirar fil Islam." There's no harm shall be inflicted nor reciprocated in Islam, and that's the guiding principle in all ethics, and medical ethics, and social and financial ethics for us as Muslims. And so we have to talk about it in the context of harm. I will draw on the Sunnah here as well. When Rasulullah sallallahu alaihi wasallam was dealing with illness, and we know he was in and out of consciousness, and falling asleep and waking up, and falling asleep and waking up. In one of those moments, his family was gathered around him. And when I was reading this hadith, it's like a scene I see all the time in the hospital or with at home, where families gathered, they're anxious, they're worried, and the patient is sick, their loved one is sick, and they're thinking, what do we do? What do we do? We have to do something. Allah subhanahu wa ta'ala actually mentions this in the Quran, in Surah Al-Qiyamah. He says, "Kalla idha balagat at-taraqi," when even as the soul is reaching its collarbones, and it's on its way out, the last moments of death, وَقِيلَ مَنْ رَاقٍ, it will be said, who can provide a cure, right? Who can cure this? And that is an instinct, a good one to have as human beings, to care for a loved one and seek treatment. And so this scene is with his family, sallallahu alaihi wasallam, around him, and they try to put a buccal medication in his mouth, right? And that's something we still do when you give a medicine inside the cheek of a person. It's faster absorption. And he, sallallahu alaihi wasallam, kind of declined it with his hand. And Aisha radiallahu anha comments that they thought it was as if any patient hates medicine, right? Hates to take medicine. And so when he became too physically weak, sallallahu alaihi wasallam, to actually decline it, they put it in his mouth. And when he woke up from that, he actually was upset and scolded them and asked, how would you like it if it was forced onto you? Now, of course, we don't have the divine knowledge that was imparted to Rasulullah sallallahu alaihi wasallam, and so I don't want to use this as a dalil or anything like that as it comes to our own medical treatments. But I do gain some guidance from that in saying that, a person's ability to choose medications comes up. And also, just because we can provide medication doesn't always mean that or treatments, doesn't always mean we should, right? So there's a difference there. Ending on advanced care planning, these are the questions that I love to ask. If you're ever on a first date, is what I say, and you really want to get to know a person, these are the questions that really you get to know a person, right? What brings meaning and purpose to your life? What brings you joy? What makes life worth living? This is what I ask my patients. That medical stuff is important. I read your chart, I read your lab values. Tell me about your values as a person. And that should really guide medical decisions, in my opinion, rather than any medical data. So,
Ramy, if I can interject
yeah.
here, there's several questions to this point and several sort of anecdotal experiences, I think. One is, you as the clinician in the moment, making a determination with the family, with the patient. Perhaps that's easier, right? The question people have been posting repeatedly here is also like, how do I do so in advance? Like and you'll come to this, I know, but just so that you have this frame of like, when is it appropriate to write a DNR, right? And what people think, when does that border on, la taqtulu anfusakum, like don't kill yourself, and what's suicide, and what is, some people say that, there's this misperception perhaps that you must seek every single intervention that is out there because otherwise you would be violating that obligation of not harming yourself.
Hmm.
So if you can just kind of touch on as we go, the advanced part of it is what is trickier, and this is where I think so many of those directives are just too challenging for the average person to administer because they ask about specific interventions rather than these like what would your goals be? They're
Yeah.
asking, do you want cardiopulmonary resuscitation and do you want, this to be, on a ventilator, this or that. So just wanted to
Yeah,
flag that that's a question that's coming up sort of as a repeated theme in the chat.
absolutely. I will come to that, all those things that you mentioned. Though I often say I usually use a picture of a crystal ball here, of a person holding a crystal ball. And there's a million and one ways your health is going to change. So it is impossible, and nor should you do this, really think about like every single scenario that your health can change and what you would want in that scenario. I mean, you can derive some experiences from how your mother or your father died, or how dialysis was so bad on this person and how you would not want that. And you could share that. But advanced directives, it's vague. And I think that's good by design, right? Not going to the specifics of everything. Because number one, like I said, your health can change in many ways. Number two, you can change. Like your goals can change when you're actually confronted with illness. I think the value of advanced directives more than anything else, and this is it here, the conversations that are happening between families to say, this is my goals. This, if I'm ever tried by illness, if I'm ever dying, like this is what would be important to me, right? And actually having that conversation makes a very difficult situation, your loved one dying, a little less difficult. It won't make it easy, but it will make it a little less difficult. And I think that's really important. A post form here that I bring up in the continuum will come back to a bit later, but that's where the DNR question comes up. So um, I'm going to go through the next two cases a little bit quickly because I think the end case is where the DNR question comes up. But I do like this case because this highlights how Muslims might see their care a little differently in the context of modern Western medicine. This is a 57-year-old Muslim woman. She has bone in the cancer, it's osteosarcoma. And if anybody's had bone pain, may Allah protect us. It's one of the worst types of pain that people can have. And despite radiation and treatments that are geared towards this bone pain, she's still having pain. And so the doctor writes an opioid medication. I know opioids, there's a lot of conversation around that. But this Muslim woman says, I do not want pain relief. I want Allah to forgive my sins. Now, redemptive suffering. We know this is rooted in Islamic tradition. Rasulullah ﷺ said, no thorn pricks the skin of a Muslim except that their sins are forgiven. Rasulullah ﷺ told someone he was with when they were commenting on someone who died without being tried and called them fortunate. They said, Hani'an lah, and he said, Wayhaq. He admonished him and said, how would you to know that if he was tried by illness, Allah would have forgiven his sins, right? Um, Physicians in this and clinicians here can be heavy-handed with medications to relieve pain. Hospice clinicians, especially, who have seen opioids, and I've seen opioids, really help people from their pain and suffering at the end of life, and there is a place for them. They will have a hard time, right, with someone that says, I'd rather deal with the pain while they're grimacing and guarding and wincing in pain. But it's something that is personal, and I honor that, right? If a person, the morphine is there, it can help. You look like you're in pain. And if the person is their own determinant of how much pain relief and how much pain they'd want to go through, especially if it's rooted in religious values like ours is. Now, I have to say one thing though, and I've seen this actually. Some people will take this to mean that I'm going to sign on for aggressive or burdensome or really painful interventions and hope for Allah to forgive my sins. That's not. I am okay in saying this, and this is me. That's not okay. I was in a talk where an Islamic scholar said that pursuing mechanical ventilation and life support for patients who are brain dead. I know that's a huge conversation. Uh, it can be applied because Allah is forgiving that person of their sins. Again, going back to removal of harm, right, is really important. We can't do that. Self-mutilation in hopes to Allah forgives our sins is not something in our in our tradition. So there's a fine line by suffering from illness and then suffering from treatments, elective treatments. All right, this is a loaded one, and I have about probably around 20 minutes or so. Is that okay, Yasser? Yeah. Okay.
Yeah, I think that's good. Just there are several questions about, the recording. So the recording will be available if you have to drop off. I know we have folks all over the country, and so it's Maghrib time and it's, different different time zones and such. But yeah, we'll aim inshallah to get around 20 minutes, and then if we have some questions and answers, maybe we'll spend a few minutes after that, just so you have an expectation of timeline.
Sure. And this is another case. Now, all these cases are actually rooted in real scenarios. I just changed the details. This is a 91-year-old patient, advanced dementia, admitted for an infection, end of life, goals of care conversation. What's important with the family is had, and they say just keep, our mom comfortable for whatever time is left. Now, in the middle of the night, the nurse pages the Muslim doctor. So there's a Muslim doctor on call for an extra dose of the opioid medication because this patient is breathing really quickly. They look uncomfortable. They're using their muscles to breathe. You can see them struggling. And the Muslim doctor, excuse me, says, euthanasia is against my religion. I do not feel comfortable increasing the morphine or giving the morphine. And I've seen this with Muslim doctors here. Loaded topic with euthanasia. Euthanasia actually comes from the Greek word eu, which is good, and thanatos, which means death, so good death. And I think it's misapplied. I mean, some people will talk about DNR orders or foregoing treatments as euthanasia or passive euthanasia. I think in what's more specific and in the context of today, euthanasia is usually just meant for medication administered with the intent to end someone's life. And that is legal in many countries around the world for patients with limited prognosis and some not even with limited prognosis. That's a whole other discussion to have. But with this, it's more about, administering the medication to end someone's life. Now, what does our tradition share around relief of suffering and knowing that there may be an unintended consequence of hastening death? Morphine, just like, as you know, with the opioid crisis, in large doses, opioids will shut down the breathing center of the brain and cause someone to die. Right? That's how overdoses happen and lead to death. And so, how do we reconcile relieving pain, suffering, breathlessness, especially at the end of life, with this theoretical and sometimes real risk of shortening someone's life? And this is where the principle of double effect comes in. I'm going to mention it because I do think there's a corollary in Islam. We know that al-umur bimaqasidiha, that the actions are judged by their intentions. And so the principle of double effect, just to mention it in layman's terms, Thomas Aquinas, Catholic doctrine, said if someone comes to your home and you're defending your home and you end up killing that person, is it a sin? Is it murder that you killed that person? And essentially the double effect doctrine or principle says that no, if there was an action with a good intention and a negative unintended consequence occurs, it is still moral and accepted. And in the context of medicine, it's often used in what I just mentioned with morphine at the end of life. And I want to go through these conditions because I think the conditions are important. I think there's a fallacy on the part of clinicians sometimes when we're talking about really aggressive and burdensome and harmful treatments and say, oh, principle of double effect. I'm hoping for this good outcome, but this thing happened. It caused a lot of pain or complications for this patient. That's not how it works. There are conditions that have to make it valid. I know I'm getting a little technical here. I promise this is the technical part of the talk. The action in and of itself from its very object be good. So for the patient that we just mentioned, relief of pain and breathlessness at the end of life, I think we all can say is objectively, that's a good action. We want to relieve suffering. The good effect and not the evil effect be intended. We're not saying we're giving this medication to end this person's life. We're saying to relieve suffering. The good effect be not produced by the evil effect, meaning that we're not saying we are relieving suffering by ending this person's life. That would be unacceptable, right? And then lastly, a proportionally grave reason for permitting the evil effect. And I think suffering at the end of life and breathlessness is a pretty grave reason to provide these medications. Now, there's a fifth one that I got from the article cited below. And I like this one, and I think it's overlooked many times, that the agents, the doctors, the clinicians, the nurses, strive to minimize the foreseen harm. For me as a doctor, I give morphine all the time. And I know the pharmacokinetics, how morphine is absorbed in the body, when it reaches its peak effect, how much to give, how much to increase each time. I'm not just giving it willy-nilly, right? And I'm monitoring that so that I am trying my best to strike the balance between pain relief or relief of suffering and pain and breathlessness and causing unintended negative consequences. So there is room here. I do think as Muslims, there is room to relieve suffering at the end of life with medications like morphine, as long as conditions, of course, are met. Okay, I have one more case to go through, and this is where DNR comes up. And this was, I think, the most eye-opening case for me in my own professional development. This was a Muslim woman, came from a long flight from overseas and developed shortness of breath during the flight. As soon as she touched down, she was redlined to the emergency room and was found to have a massive clot in her lungs and was in respiratory failure. So her lungs weren't working. And she was on something called BiPAP, which is non-invasive positive pressure ventilation, a mask to force air in and out. So it's the step before life support when the tube goes down the windpipe and you're hooked to a ventilator. So palliative care was consulted for code status, and code status means that what you touched on a second ago, Yasser. Um, Code status is whether or not to resuscitate. So how I like to say it is if a person dies, essentially, if there's no pulse, person's not breathing, do we do CPR in efforts to resuscitate the heart and to, of course, hook them up to a ventilator and life support? Or do we not attempt to do that? And often it's called on the form, it's called allow a natural death. I think that's a loaded term and kind of skews, maybe persuades one person one way or the other. But those are the terms that are used. Pulling another study, it's really important to know what code status means. When we go to get chemotherapy, we ask about all the side effects and all the intended outcomes for it. And so for patients 65 years or older in the hospital. And so when you're in the hospital, this is a good, actually, point of clarification. You're sick, right? So I say CPR is a great intervention that human beings have developed. We saw Damar Hamlin, for example, last year, a football player, an NFL football player, collapse on a field and was resuscitated to where he's catching interceptions and playing on the field again today. That's amazing, right? CPR works when the heart fails and it's trying to take the body with it. So he suffered a fatal arrhythmia because someone shoved their helmet into their heart in the wrong time of the heart rhythm. And the heart was trying to go and take the body with it. And that's where it's effective. All right. Where it's not effective is when the body's trying to go and then taking the heart with it. So with advanced cancer and organs are failing and bodies failing, and the last thing to go is the heart, that's when CPR and resuscitation tends to not work as well as we think. In this study, 49% of the people in the hospital never even made it through the resuscitation. So we're already coin flipping at this point. Another 34% never left the hospital. So you can presume the majority of those are on life support and end up dying on life support, usually sedated in the ICU. 7 died within 1 year of discharge, so they got a year out of it, and another 10 were alive 1 year after discharge. So those are the numbers there.
So to
It's
me,
important
to me, that just kind of reiterates the point about like revisiting these directives as life changes, right? Like the healthy prognosis sounds like, you know, you're young and you would want the intervention, and the same intervention if it's going to cause a whole bunch of broken ribs and all sorts of other problems that are going to come. At that point you would want the directive to say something different. So this is sort of just like just like the estate plan might change, the directive probably should change over the course of one's life, right? If we're thinking about it from an advanced perspective.
Absolutely. And that's why you have to always revisit periodically, right? Your estate plan and your advanced directive.
One question I have as you're going through this, another term that I think is confusing is there's one that I don't want any heroic measures.
Yeah.
So what does that mean?
You know, medicine, I can give a whole talk on language in medicine because that's a lot of what I do. And I think medicine with language, unfortunately, we hear these euphemisms, these adjectives that really skews the full picture, right? Heroics colloquially is usually meant this, right? Like life support and aggressive interventions, Hail Marys where, you don't know if it's going to work or not and can cause a significant amount of harm, life support. That's usually what it's meant. But just using the word heroics, I mean, what does that actually mean, right? Same with, for example, comfort care, right? That's something that comes up often. People on comfort care sometimes are not comfortable because their disease is so serious, but comfort might sound better when we bring it up. Doctors sometimes ask, do you want us to do everything possible? And for a person who's sick, or a daughter who's with her father who's sick and comes to the ER looking for treatments, you say, of course, do everything possible. What does that mean, right? And so that's a whole different discussion topic and something I do on my day to day to really, spend time like peeling the onion, the layers on the onion to really know what is meant and what is important for that person.
And what about, I know you're going to get to this, but what about the first responder, right? As you come to this, yeah, on this post form, like when they see something, like how likely that's different. You're in the hospital, like, that you've already gotten there. But if that DNR is on the fridge,
Mhm.
how does that change the analysis? Because a question we get all the time is like, okay, so I did this directive, like, who knows about it? Where is it? Where is it stored? How do we ensure that it actually has some efficacy? And if you listen to the old sort of advice, it was like put a copy on your fridge and that kind of stuff. And obviously now there's digital versions of this, but if you couldn't, yeah, I guess this is a perfect segue into that.
It is. It is a great segue. This is the pulse form. Every state has a pulse form. There are little variations. I looked up Arizona's. This is very similar to California's. It's a hot pink form, and the reason it's hot pink is because it can be found in the time of an emergency fairly easily. Yes, patients, families are usually told to put it on their fridge because that's where paramedics and EMS are trained to look. Um, I often tell people that if you don't want to look at it every time you reach for a snack, put it on the side of the fridge. So, and they'll know to look. And the default in this country, for better or for worse, without this form, is to do CPR. So if paramedics come in and don't see this form, and there's a lot of defensive medicine happening, fear of being liable, they will do CPR. Unless there is a physician's order, and this is what it looks like, to not do CPR. An advanced directive, sorry, paramedics are not going to comb through, 5 pages of an advanced directive to figure out whether or not to put, do chest compressions. This is the form they look at. And the main question on this form is letter A, do we do CPR or not if there's no pulse? Um, I know I brought up statistics. I do have to bring up personal stories, and I know we're swayed by personal stories and storytelling, but they're effective. I have a loved one in my own family and who I really implored to try to get this pulse form done, and unfortunately did not for, an older woman in our family who was dementia and clearly in her last months of life. And when she coded, the EMS showed up, was doing code status. Her son showed up shortly thereafter. And at 20 minutes of doing this, my uncle implored them to just stop. And yeah, it was my uncle, and implored them to stop. And this is not founded, at least from what I looked, and yes, you can help me out here, any founded in any law or legal code, but he was told that we have to do it for at least 30 minutes before we say no. And I've seen mixed things in practice from paramedics. And she got her pulse back in 25 minutes, but was completely neurologically gone. Right? Eyes dilated, gag reflex. But now she's on a ventilator, and the family has to decide whether or not to withdraw the ventilator. Now the questions are being asked, like in this webinar, what does the SNAM say? And all the while, we could have had these conversations ahead of time, right? And I don't fault the family. I fault more the doctors. Like the doctors really need to initiate these conversations and share what's important and what they would recommend for patients. So
Because
that's the
we have a
pulse
lot of
form.
doctors. We actually have a lot of doctors on this webinar.
Oh,
But
good.
one point, you mentioned this point about defensive medicine, and so that drives so much of how medicine is practiced. Obviously, insurance drives a huge portion of how medicine is practiced, and who has and who doesn't, and what treatment they receive, and all that. But this defensiveness of plaintiffs' attorneys does. And I was actually reading, interestingly, there are now wrongful life lawsuits for failure to
Wow.
adhere to the directive. So the inverse,
Mm.
where now the physician has to be cognizant of the directive because plaintiffs' attorneys have brought wrongful life lawsuits, given the suffering that somebody would potentially have because of the intervention. And so it just makes obviously the trickiness of medicine even greater.
Poor doctors
Yeah.
caught in the middle, right? So that's the pulse form in DNR. Now I'm coming back to this to conclude. I'm coming back to this case because I think this is a good place to kind of put all of this in a basket, right, and gift wrap it because we're human beings, right? So the son who comes as this conversation around code status comes to the hospital, and he's a physician in Saudi, and a family meeting is held around it. And he says, in my religion, we must do everything possible. If we must intubate, then intubate. We see this all the time, right? I'm consulted sometimes by people in the community or in my family, and the imam or someone says, Islam says to do everything, right? Now, what does that say? And about withholding and withdrawing life-sustaining treatments? What does our religion or our scholarship in our religion say? I hate to say, I hate the phrase, "What does Islam say?" Because the scholars of Islam say a lot of things, and it's one of the ni'am of our faith that there's ikhtilaf and difference of opinions. And there's a study here that kind of highlighted some of the fiqh councils around the world. Imana as well as listed as their giving their ideas around this. And you look at some of these things, and they're usually vague, right? Like, if no chance of survival, is there always, can someone truly say there's always a no chance of survival? What does survival mean in that context? Terminally ill, okay? Brain death, that's a conversation that we won't really get into today. But what does that mean? Imano was probably the more specific one that said persistent vegetative state, where you can withhold or withdraw. But what you have here with these fiqh councils, and I like to highlight this because this is really important, is three parties that come to medical decision, especially if a patient stays on life support at the end of life, dead by neurological criteria, what to do. Autonomy is king in the Western medicine, which means that's the driving principle of ethics. What does the patient or family want? Informed consent. And there's a rich history, and we can talk about this, yes, in a future webinar, about cases in the United States, legal cases that went up to the Supreme Court to really drive this idea of informed consent and autonomy and away from paternalistic medicine. Now, Muslim patients, I don't care if you've never prayed a rak'ah in your life. If you are met with death, the family will inevitably ask the religious questions because we're meeting Allah, right? So what are we supposed to do? So they'll go to these councils maybe, right? And say, what does Islam say? What is the scholarship out there? And we just saw on the previous slide that the councils defer to a lot of clinical judgment, right? Brain death, no chance of survival, terminally ill. Who's best to answer those questions? Usually a clinician. And on top of that, what muddies the picture is usually a family member, and it's never the family member that's with patients at every clinic visit. It's the family member who flies in to visit Ammo, and oh no, someone in our community, their doctors told them that they were going to die, had the same thing, and 6 years later they're working. Don't believe what they say. Throws a wrench in all the conversations that are happening. On the other side, there are ethics committee in hospitals, and I chair the ethics committee in our hospital. When sometimes doctors feel moral distress at providing some treatment that's non-beneficial, and there are non-beneficial treatment protocols where ethics committee meet and sometimes make a decision against what the families say. And they have an appeal process that they can go to and try to find another hospital. Good luck. And that makes it more hairy. And then on top of that, what Yasser mentioned a second ago, the imam, the local imam, this poor local imam. I mean, custodian of a masjid, fundraiser, teaches our kid Quran, nikah and funeral processions. And then we got to talk about brain death and life-sustaining treatments with him. And some are brazen and will say, an opinion. And some, I remember the first time I gave this talk, subhanAllah, I was in Los Angeles, and the imam of the masjid that I gave the talk to, and it was a terrible talk, I usually say, because it was my first time giving it. And he gets like eyes this big and says, I have this community member calling me about X, Y, and Z. What do I tell her? Right? He didn't know, right? This is messy. We want to avoid this. I know I want to avoid this at the end of my life. And the way to do it, I think, is to really have these conversations before things get hairy, to sit down with family, to know, what's important to them and their values. So, 5 more minutes. I remember myself in this case because I had just come, I was doing this research and reading, and Saudi had a fatwa in the 80s that probably was the most specific around life-sustaining treatments. And they deemed that a patient is unfit if three trustworthy Muslim doctors say that the disease is unresponsive to treatment and death certain, or state of mental inactivity, untreatable brain damage, or resuscitation would be ineffective. Still some vague points there and hard to tell, right? It's always gray, but at least more specific than the others. So I thought, "Hey, this guy's practicing in Saudi. Like he knows, he's a physician, right?" And I try to bring it up with him. Oh, mind you, in the fatwa, it says that you don't need to turn to the opinions of the family because it's not their expertise. And they talk about provision and withdrawal of life supporting treatments. And so I bring this up and I'm like, I got this in my back pocket. I'm a Muslim palliative care clinician. I have all the hats. I check all the boxes. And he just tells me, look, I'm the doctor in the family, and I don't want to be the one to be seen as the one who decided our mother should die. Gut punch, right? For me, a huge gut punch. And I knew then it's much broader than fiqh, than what does Islam say, right? We're human beings, we're grieving, emotional. And I think we could say that our community doesn't do very well with emotional processing, especially in light of all the mistrust in healthcare and in medical institutions, founded medical mistrust against healthcare institutions. But this is the part where I say that if we spent just like half of the time talking about planning and religious scriptures and fiqh and all ethics, and I think that's all important, just to deal with grief and emotions and how we do with that in our family, I think we would all be better off, right? We would all be much better off. And so that's a good place to end, Yasser. You might have a couple questions that come up, but before you do, I just wanted to highlight the objectives. We talked about difference of palliative care and hospice. Palliative care, not always end-of-life care. Hospice is. The four qualities that make a good surrogate decision maker, right? They know that they're reachable, they know your wishes, they can act on them. We talked about redemptive suffering and harm and autonomy in Islam. Hopefully, you know the difference between advanced directives and pulsed forms, physician order in one, a legal form in another, and they're not mutually exclusive, and they're different things. And then lastly, we talked about our beloved Rasulullah sallallahu alaihi wasallam and the practices at the end of his life. Um, so with that, I want to leave this slide up for a second because, and I'm sure Yasser, you probably have a question or two that we can touch on.
Yeah, absolutely. No, Jazakallah khairan. I mean, absolutely beneficial. I learned a lot, and I'm sure everybody here would echo that. Um, there's so much to digest, and one of the things that we don't want is to have sort of this decision paralysis as one of the takeaways. Like, oh, it's too complicated. I mean, I think your point about at a minimum creating a directive to designate the agent, right? Like, even if we're not super clear on the specific interventions and the, what's appropriate or not, if at a minimum, like, we designate people that we think are the most competent, upright, intelligent, objective, responsive to your point about the four, things that you look for, I think at least we can be confident that that person will then consult with the right people and make the right decisions. Certainly, having those conversations, articulating them, I think is very important. And one of the things that I find the most useful about sort of that advanced directive is to eliminate the sort of feeling of guilt that is associated that the decision maker has that you articulated, like that burden, whether it's burden or guilt. If someone had articulated that in advance, then it mitigates the possibility. We actually had a case where, family members came and told one of the people who was a physician and also was an heir uh, that you're trying to kill this relative so you can inherit their money. I mean, talk about like the most just offensive things you could say to someone as their parent is passing, and the relative flies in from out of state and says you're trying to kill your parent to take their money or whatever, right? Just even though, and then the parent ended up with tremendous suffering afterwards, and in a home that was just so very difficult situations. I think can be mitigated by the agent selection. and then addressing them. And I think hopefully, as we said, we'll have a goal to enhance the directive. We do directives. So one of the reasons that we have this slide here is that, as I mentioned at the outset, the advanced directive, which we didn't really talk about, but it contains a few different documents. So the advanced healthcare directive and the living will in some states are two different documents, and in some states they are one document. So one designating the agent, the other designating the specific instruction. And then part of that directive, we didn't get a chance to talk about this today on this rich conversation, but organ donations. I mean, I get that question every single time we start the conversation is, what does Islam say about organ donations? I mean, who's Islam, right? As you mentioned. And so that's part of it. And then that directive talking about sort of post-death wishes with respect to one's body. I mean, alhamdulillah, within Muslim communities, we generally have an understanding that everybody gets an Islamic burial, ghusl, janaza, etc. But it's important to memorialize that as well, especially for converts, right? I think it's critical that that's articulated. I had one person come to me and said, my mom said, funerals are for the living, not for the dead. It was a convert. And they were like, I've got to write down my wishes. Otherwise, they're going to bury me as a non-Muslim. So things about, not having an autopsy, making sure that, your wishes on organ donations are clear. And then inshallah, that'll be a separate topic of its own. And then post-death, what happens to the body? All the karama, what I could karamna bani Adam, right? All of those discussions are based on notions of karama. So we'll talk about all of that. I want to thank you so much for all of this information. As I mentioned, if you'd like help with preparing your directive, reach out. We'd be happy to connect and talk to you about that. There are lots of resources online as well in different forms. And then, as I said, our goal, I want all of you to make dua for that, is to really be able to develop a service that can provide a directive that is kind of one that you can create by yourself, that is valid and legal in all 50 states, that will guide you through the interview process, similar to some of the other ones that are available online, but from a unique Islamic perspective to address these considerations. Let me just run through a few of the questions.
And I'm looking at the questions, and I couldn't look at the questions while I was speaking, but so many questions, and it opens up so many discussion points. On the concept of DNR, I know that came up a bit. I attended a lecture from a scholar, because DNR in and of itself, for any practicing physician here, you can't call it certain, right? And often for most people where it actually happens, it's actually more on the mawhum, the speculative side of things, or coin flip side of things, and using the efficacy of DNR and whether or not it's mandated to actually pursue it. You can say that potentially that it's never mandated because of the speculative nature of whether or not one will survive the actual intervention. The other point that someone brought up, and this breaks my heart to read, because DNR shouldn't mean let me die. It doesn't mean that. It means when I die, allow that to have happened without any chest compressions and life support. But it does sometimes get misconstrued by physicians and clinicians of, oh, this person would not want any medical treatment, which is farther from the case. And I've had conversations with physicians and clinicians to say, no, I mean, DNR doesn't mean they don't get antibiotics or don't receive the good care that you need to. So it's unfortunate. And I think DNR orders is just one piece, right? We talked about racial inequities and things like that too, where family members have to be fierce advocates for patients when they interface with healthcare. I wish it wasn't so, but that's the reality of where things are. Yeah. I don't know if you have anything else, Yaser, that you were looking at.
No, we will, inshallah, upload the recording so that if you weren't able to catch all of it, or you want to share it with others that you think could benefit, you'll certainly be able to do that. I do think, this is, inshallah, the start of a conversation that we will hopefully continue, and that can provide some benefit and resources for folks as they navigate something that's going to impact all of us, either as the patient or as the decision maker or as a relative, in some capacity or another. Like, this will touch every single person. And And, obviously, unfortunately, we're not gonna be able to cover every question here, but,
Can I answer one more,
yeah,
Yasser?
please go ahead. I think
Way over time, but I'm having fun here. It's a great conversation. EOLOA, so End of Life Option Act. This is something that's legal in a few states. I think it's 7 states in DC or 8 states in DC, where a physician, through a process, can prescribe medications to someone with a limited prognosis to take, and they have to be of sound mind and body to take this medication to end their own lives. So they drink a medication to end their own lives. And I've had patients who've pursued this. I cannot reconcile from what I've read and what I've been taught and what I know that something like this can find its place as Islamically sound or valid. Relief of pain and suffering, and we talked about the principle of double effect and how that might lead to an unintended consequence. This is with the intention to end one's life.
Mm.
And so I think there's a line there that I just want to make sure be clear about, at least from my understanding. Allah knows best.
appreciate that. Instead of having to change the directive, is it possible to have the directive have different situations? I mean, certainly one can attempt to create a directive that has a bunch of contingencies and situations. I think that's a little bit hard, and one should change. I will mention this point that perhaps the three most famous cases in
Mm.
American legal system around end of life dealt with people under the age of 30, right? So not what one would expect with respect to elderly, but rather young, healthy people, otherwise, or perhaps in some cases with a disease, but under 30, where two loved ones have very competing um, perspectives, right? And that leads to, courts making determinations, right? The worst possible result you can sort of arrive at is not even a healthcare facility and the doctors, but rather a judge, right? Instead of the family. So no one's too young, I think, for a directive. I think that's
18 years old. So
18 years old.
adulthood.
Oh,
Yeah.
one last thing, actually. This came up as well, which is to say, not necessarily end of life, but one of the other use cases for directives is that, or for a healthcare power of attorney here, and I use this in the broader sense compared to the directive, but designating an agent, is that parents don't automatically have decision-making authority for their college-aged children.
Mm.
And so we've had that come up. So in the absence of a healthcare power of attorney under HIPAA, the parent who, has been obviously doing everything for their child, who now went off to college, doesn't have the right to make decisions for their child, who they think is a child, but is 19 years old and off in college. And so, and then we've seen broken families where the parent is not able to make decisions, where they need to, because they didn't have a healthcare power of attorney. And so I think that's another use case, just to designate the agent. If you have kids who are 18, make sure that that is part of one's planning.
Yeah.
So
Absolutely. Yeah, I don't think we can talk about all these specific scenarios. There
yeah,
are some things that I think would be useful. We didn't talk about organ transplantation today, and we didn't also talk about artificially administered nutrition and what the Western kind of viewpoint versus the Islamic viewpoint is on that. So there are some big themes that maybe can be built into one, but we can't go through every scenario. On top of that, I love that Good Advanced Directives has a blank sheet at the end as a letter to whoever it is that's going to be called to make your decision, right? Like giving them words of comfort. I know I would want to do that for my son if he were ever, called to make a decision for me in the future. So that's also a good practice as well.
very good. So it sounds like we'll have a part two, inshallah.
Inshallah ta'ala, may Allah grant us tawfiq.
Allah grant, Allah accept. Thank you all for joining. Inshallah, I will follow up with a recording for those of you that joined. If you have questions, feel free to reach out. Thank you again, Dr. Ramy, for a very informative, very beneficial discussion. May Allah subhanahu wa ta'ala bless you all. Jazakumullah khairan. Assalamu alaikum wa rahmatullah.
Wa alaikum.